Excited to have Dr. Jim DeMaine from Skyline in Seattle with us to talk about his latest book, Facing Death. He is a longtime emergency care and pulmonology specialist. He was chief of medical specialties and co-chaired the ethics committee of what was Group Health Cooperative, now part of Kaiser Permanente. And he's a clinical professor emeritus at the UW School of Medicine. His often dramatic experiences with patients' near death led him to blog and then speak about their stories with special attention. Sorry, I need to mute someone. With special attention to the issue of advocacy for patients who are unable to speak for themselves. He has also, early in his career, been in the U.S. Public Health Service, stationed in Helmand Valley in Afghanistan, treating Peace Corps volunteers. Some of us, not me personally, but some of our residents have been Peace Corps volunteers as well. So that certainly resonates. He also spent a sabbatical year at a hospital in Saudi Arabia. So he's had a number of experiences outside the US. Jim, welcome.
Well, thank you so much, Lee. And Lee's a wonderful correspondent and organizer to get this put together. And I really appreciate the opportunity to meet with everybody. And I so wish I could be with you there personally, because I'd love to know what draws you to a discussion like this. And I'm sure you all have feelings or stories around this very difficult subject. I kind of became interested in this when I was near retirement in 2003. I had a lot of stories in my head from patient care over the years, and was quite aware from my experiences in the critical care unit that often people had not had the necessary discussion about end-of-life choices, and there's often a lot of confusion or angst. So we put together a program called Your Life, Your Choices, and I would go around to the Kaiser clinics, group health then, and meet with people 65 and over to have this kind of discussion about advanced care planning. And I also started blogging pretty frequently about end-of-life issues. And the reason this book came about, you say it's one of my books, this is my only book, but the reason the book came about is my next door neighbor, where I lived over in Clyde Hill, was a Microsoft director, but also jack of all trades. He was CEO of Crosscut for a while. He was at the Gates Foundation for a while. He owned a couple of small baseball teams, one over in Walla Walla. Just an interesting guy, but he also started a publishing company, publishing nonfiction that he thought would be of interest, and did business books and hockey book. And they got together and thought that, putting my stories together in some kind of book format would be a good idea. So I worked with Greg and a very good editor, used to work with the Seattle Times, and she helped me kind of string a lot of the stories together, make it more coherent, because it's hard to turn a blog into a book. And then it finally, I had a lot of time during the pandemic to work on this, and a long-suffering wife who allowed me to do it, but managed to finally have it come out in September. And so far, I think it's been well received. It's not a major publishing company, so we don't have a publicist that's pushing it out around the country, but I am getting some calls even from out of state to do a radio interview or a seminar. So it's kept me busy, kind of kept me out of trouble, but it's been my major volunteer work. I think what I'd like to do, and this will be the only story I'll read you from the book, but I'd just like to read you one of the stories, because so often they're about the ethical dilemmas. What choice should we make, or what choice should a family or loved one make in a difficult situation? And this one is called Honor Your Advance Directive or Not. I gave a lunchtime talk at a retirement home to a group of about 60 highly educated folks aimed at educating families about the value of advanced planning and how to make their values and wishes known. The talk, Your Life, Your Choices, is one I give frequently in my audience, and this day included judges, chaplains, and professors all engaged in dynamic discussion. As usual, I spoke about the value of advanced directives for preserving patients' autonomy and decision-making when they are no longer competent to speak for themselves. Afterward, a woman quietly approached me and asked if she could have a moment of my time. My husband has worsening Alzheimer's and can no longer care for himself, she said. He's been transferred to a memory care unit. The doctors say he's no longer competent to make any healthcare or financial decisions, so the burden is entirely on me. But I have a problem. A few years ago, my husband said that he would want full life support, including fluid nutrition tubes to sustain him, and he signed papers saying so. But I don't know if that's the right thing to do now. So I asked her if she thought CPR, cardiopulmonary resuscitation, would benefit her husband if his heart stopped. No, she replied, but I'm not certain what his wishes would be in that situation. He never talked about quality of life issues much. This kind of situation is why I advise people to write an addendum to their living will while they're still competent, giving a personal interpretation of that term, quality of life. What does it mean to you? Without such statements, it can be difficult for surrogates to make such decisions on behalf of patients who are too ill to discuss their status. It's rarely easy in these gray zone situations, so dementia directives are being developed. And as a side, I'll talk about that a little bit, but there's a professor, Barack Gassner at the University of Washington, who's developed a dementia directive. And if you're interested, you can just Google dementia directive. And I've got the website in the back of my book as well. In the meantime, a statement about your biggest hopes and fears can go a long way in helping. What is an acceptable quality of life for you personally? And what would lead you to think it's time to pull the plug? The more we can let our surrogates know our deepest feelings in these matters, the better their decisions will be on our behalf. I tried to reassure the woman before me that doctors feel obligated to do no harm, and that many would not offer CPR and intubation for her husband. I advised her to talk with his doctor and palliative care or hospice provider, as well as a hospital social worker and her spiritual counselor. But she'd raised an interesting point, which I later discussed with a healthcare lawyer. What if your advocate's best judgment runs counter to your directive? In cases of advanced dementia, for example, you essentially have become a different person from the one who signed the form. The lawyer felt that this woman, as her husband's legal advocate, had leeway to interpret his wishes using substituted judgment. If done in good faith, she was not necessarily bound by the letter of the document. In other words, circumstances can change, and rigidity in the face of new facts serves no one. Sometimes common sense outweighs the living will, the lawyer told me. Yes, someone could sue that the letter of the document wasn't followed, but it's unlikely. Either way, the advocate has quite a burden to bear. The point is that we all need someone with us at the end who knows our heart. For example, the composer Chopin had one great fear about death, the possibility of being buried while alive. According to Stephen Lagerberg, by the way, a physician colleague of mine, who's a pianist and musician living part-time in France and part-time in Seattle. But according to Stephen Lagerberg in his book, Chopin's Heart, the musician was so adamant about avoiding this fate that he had his physician promise to remove his heart at death, thus ensuring that he was in fact dead. Chopin is buried in France, but his heart is enshrined in a church in Poland. May we all have physicians that know our hearts and honor our wishes to this degree. So that's just one story out of many. The book is structured with sections that are somewhat topical, but it's really a series of vignettes from my life in pulmonary and critical care. And as I mentioned in the book, when I started in my training in medical school in the 1960s, the University of Pennsylvania, there were no intensive care units. We would have somebody with a heart attack and they would just be admitted to a bed. And if their heart stopped, their heart stopped. You know, we didn't have CPR, we didn't have defibrillators. They were just beginning to come out at that period of time. And then, so critical care didn't exist. Pulmonary specialty was pretty much tuberculosis. And so I had to learn this as I went along. And I had my boards in internal medicine, and I wanted to go ahead with pulmonary training and certification. And I got support from the head of the program at the University of Washington to grandfather in, be able to take my pulmonary boards. And then the same thing happened with critical care. There wasn't certification in critical care till 1987. I was able to sit for those boards as well. So this whole field has evolved as I had. And I made my choices as I went along. And as I said in the book, I was a story that could have had many different endings because there were so many choices along the way. At this point, I'd like to screen share, if you don't mind. And let's see. Okay, can you see that screen, folks?
Yes, excellent, Jim.
Okay. So I think I'll be able to read the screen. I still see the video at the side, but that's fine. So, okay. So this is an issue of the Atlantic magazine a few years back with, it's about aging, and it says living to 100 will be common. Of course, this fellow on a skateboard has pretty scrawny legs, looks like he's losing balance and looks like he's due for a hip fracture. I don't know quite why they portrayed him that way. But it is true that a number of us are going to live to be 100. A baby born now is very likely to live to be 100. So this is kind of what's called the silver tsunami of aging, and we're part of it, and we're making choices. You've made a choice, and I've made a choice to live in a CCRC with a lot of security and planning for our aging. But you might notice at the bottom of this magazine, there's an article by Ezekiel Emanuel called Why I Hope to Die at age 75. Ezekiel's a brother of Rahm Emanuel, and he's an ethics professor and oncologist at the University of Pennsylvania. But I objected to the article. I think he wrote it somewhat tongue-in-cheek, but he pretty much said, you know, at age 75, we ought to get out of the way. We're just going to use up healthcare dollars. And he would just soon not even take an antibiotic if he was 75. So I think it smacked of ageism, and I wrote it. I pushed back pretty hard in the little vignette I have about this in the book. But one of the reasons we're here is because we're facing up to the fact that someday we're going to die. William Heron says everybody's got to die, but he always believed an exception would be made in his case. And that's denial, and it's healthy, actually. I think it's fine to be in denial day by day, but it's something that allows us to enjoy life and not get depressed. But on the other hand, it's something we need to face up to. And one of the startling facts is that as we get toward the end, particularly in the last few weeks prior to dying, more than half of us are unable to make healthcare decisions during those days and weeks. So that's where we get into advanced care planning, which is really my interest. And the reason I wrote the book is to encourage people to have the conversations and make sure their plans are in place and adhered to and understood. So first of all, we need to clarify our own beliefs. We need to choose a spokesperson, and understand life-sustaining treatment. You know, if we're going to have an operation, we're going to want to have informed consent. We're going to want to know what are the benefits of having this procedure, what are the burdens, what are the downside. But with life-sustaining treatments, we don't get much advanced training, if you will. You know, what are my odds if I have CPR? If I went on a ventilator and I had COVID, what would be my chances of coming off? So understanding those things is very important as we make our plans. And then we need to understand advanced directive forms, but I never really emphasized the forms as much as I did thinking and particularly choosing an advocate. So we need to think about what kind of medical care we want as we age. We acquire medical conditions. We see the doctor more. Our various body systems are starting not to function well. We develop cancer, heart disease, or some other medical condition. So where do we want to be at the end of life? I think we've kind of chosen that being in a CCRC, but then we're going to have to make a choice of we want to stay in our own individual units, or would we want to go into the healthcare unit or something in between. Who will speak for you when you can't speak for yourself? I'll get into this quite a bit more. And then how are others going to know about my wishes? So let me minimize this here. Okay. These are some resources that I think are useful, and I note them in the index or in the at the end of my book. There's a website called Prepare for Your Care, which has an excellent advanced directive and a way to store them on their website. My Directives is another excellent one. They have directives for all the states, and both of these sites combine the living will and durable power of attorney into a single document, which I think is a very useful way to do an advanced directive. Again, they can be stored online, and you can even email them to your relatives or to your physicians. The Conversation Project, these are all, if you just Google these names, you'll come up with the information. This was started by Ellen Goodman, whose mother had what she would call a bad death. So she wanted people to start to have the conversation. And it's kind of almost a one-stop place that you could go to for everything. But they've got little starter kits, card games you can play, other things like that as a way of breaking the ice. Some people want to go directly. They'll go to death cafes, which are meetup groups that happen in coffee houses. And then there's a site called Let's Have Dinner and Talk About Death that Michael Hebb, who was at the University of Washington before, and he started this actually worldwide thing where people get together over the dinner table and have these serious discussions. There is a group in the state of Washington called Honoring Choices Pacific Northwest that is funded by the Washington State Medical Association and the Hospital Association. And I'm on their advisory committee, and they are in the process of revising and updating both the PULSE form and their recommended advanced directive. And that is the process that's going on, and you'll likely hear more. But their mission is to educate people about advanced care planning. I think it's just a good idea to write an essay. What's important to you? What are your hopes? What are your fears? My mother wrote a letter that she included that was very supportive to all of us. Or some people are list makers. There's value lists that you can make out. There's no way you can cover every situation. So I think stating your general values is so useful. I do have a letter an essay in my book about an essay that a patient handed to me that he wanted included in his advanced directives. And I thought it was a beautiful letter. And I actually have used most of it myself, and I put a copy of it in the book. So you can attach these to your advanced directive forms. They can be scanned into your electronic medical record. And you want to make sure that copies go to your advocate, your attorney, to your family, and to your healthcare team. And the real question is, and I talked to Lee a little bit about storing these. What we do at Skyline, and I think you have something similar, these documents need to be found. I happened to witness a lady not too long ago who fell in her apartment and broke her hip. And while she was lying on the floor and medical one was being called, she was yelling at her husband as to where to find the insurance form and where to find her advance directives and where to find her list of medications. They're all scattered in different areas. It's a good idea to have these all together in one spot. So if medic one arrives, they can find them. And what we do at Skyline, we have this hanging folder we put inside the kitchen sink door. It doesn't just have the pulse. We recommend people put in their medical information, their main diagnosis, their medications, any advance directive, and their pulse form. Also, insurance information should go in there as well. So I should add that to the slide. But so this is removable, it's Velcro attached. The whole folder can go on your gurney to your hospital if you're being transferred to the hospital. So it's just one way. The pulse form is hard to carry around. Some people will get a bracelet or medallion saying, I have a pulse form, I'm a do not resuscitate, and they'll have a phone number on it. There is no Washington state law that, in quotes, allows these, but some people use them. And when I've talked to the medics, they said they probably would honor them, but I think it's since it's not in Washington state legal code, it's kind of up in the air as to whether these would be honored or not. I think we need legislation to allow medallions and bracelets to be more legal. So thinking about quality of life, you have to think about what makes life worth living for you. And given the nature of your illness, what are the most important things to achieve? And this can vary for all of us. In the book, I note an 18-year-old girl with cystic fibrosis, very advanced, getting near end stage. She had become diabetic and malnourished and had frequent pneumonias, but she was excelling in school. She wanted to become a nurse, and she was social. She was beginning to date, but her goal in life was to go to her senior prom over at Redmond High School. And her mother was reluctant because her health status was so fragile. But, you know, what is life for but to live? So she went and had a great time. Even her boyfriend said, you know, we don't really need to go, but they had a great time. But shortly thereafter, she ended up not being able to breathe at all. 911 was called, and they took her into a community hospital, intubated on life support, and she was transferred to our institution. And we knew that she'd never get off the ventilator. I had had her seen at the adult cystic fibrosis clinic at the university, and my colleague there came over and we sat with the family in our intensive care unit and talked about withdrawing the ventilator. And the ventilator was the only thing keeping her going, and it was a dead end street. It was prolonging her dying process. So mother, obviously very reluctantly and tearfully agreed to the ventilator withdrawal, but the girl's birthday was on the next day, so we skipped that day. And then a day later, the process I would use, and I think a lot of physicians do, is you turn off the monitors, you make the room as technology free as possible, gave her a lot of sedation so she would be comfortable when we removed the endotracheal tube. And then mother came back in and sat with her at the end. And the mother was so sad, but at the same time proud that she allowed her daughter to do what mattered most to her. So it's just one of many stories. So we get into our biggest hopes and our biggest fears. And this raises the question, okay, what is a good death? And it means something different to all of us. I had a radio interview with Katie Sewell on KUOW a number of years ago, and that was her first question to me, and I was a little unprepared for it. And I said, well, it really means that whatever's important to you is adhered to, and that you're truly listened, deeply listened to, and that your whatever your wishes are followed. So over the years, I've kind of put together from what people have said to me and what I've read about what a good death is. Certainly in this day and age of good palliative care and hospice care, I think we all want pain, symptom management, whether it's shortness of breath, whether it's nausea, whether it's a spiritual crisis, whatever it is, we want those things managed. We certainly want whatever our wishes are honored. And that could be very, very different. One lady wanted everything planned down to the songs that were sung at a memorial service, what china, what crystal, and what toasts were going to be made. But that was all very important to her to make sure that the family agreed that whatever her wishes were. And then we need some kind of preparation. We're never really prepared until we're there. People ask me, what is it like to die? And I say, I have no idea. I've never done it. You don't get any practice at this. It's a unique one-time event, but we want to prepare for dying. And I think maybe instead of saying what's a good death, we should say what's a good dying process. But some kind of preparation, both spiritual and on natural plane. And then a sense of completion of goals. Did you get to that anniversary? Did you see the birth of the grandchild or great-grandchild? Those things can be very important in our lives. And then a sense of leaving something behind, whether it can be personal values, it can be contributions, it can be a grant, it can be just something very simple that you've written. All these things can be very important to us. And of course, we want to be at peace, and a lot of people say a major fear is dying alone, but have somebody around, that warmth of human contact. So the causes of death, it's kind of interesting that some of these things are going in the right direction. If you look at, some of the major diseases, heart disease and cancers and HIV, we see falling death rates. But if we look at Alzheimer's, it's certainly up there, unfortunately. And this is the most unfortunate thing that's happened to us over the past year, and that is now that COVID, it's falling again, but I still think we're greater than 3,000 deaths a day. It's up around 4,000 even. But here's heart disease and cancer, and then Alzheimer's still very high on the list. And smoking has gone down. We're seeing less heart disease, and we're seeing certainly less heart attacks and less chronic respiratory disease. But fortunately, this slide should be changing. We're seeing dramatic decreases in cases right now, and hopefully this trend will continue. It's not due to the vaccine yet, because we don't have enough people vaccinated. So it may be somewhat a combination of a whole bunch of things, from seasonal, less travel, masks and social distancing, but it's hard to know. Some viruses just wax and wane, so we can't let our guard down yet. This is from the Onion. It's the world mortality rate. It just reminds us that indeed the world mortality rate is going to remain at 100%. What we're talking about with a lot of behaviors and lifestyles is having kind of good years, meaningful, resilient type years as we approach old age. So there's some interesting statistics that I didn't realize. I looked these up recently, and it was by an article by Atul Gawande in the Journal of American Medical Association not too long ago. But one thing, it was called the glass is half full, the glass is half empty. The glass full part is that the chances of dying in a hospital are less and less. In other words, we're able now with good modern hospice and good home care, good nursing care, that only about 20% of us will die in a hospital. And not too many years ago, it was well over 50%. And when I visited France and talked to doctors there, they almost always tried to have people die in a hospital. You know, why in the world would you have them die at home? So it's somewhat cultural and will vary country by country, but I think we're leading other developed countries in terms of that. And the use of hospice is improving. Certainly more than half of us, as we're dying, will use hospice. And one of the issues with hospice, as I mentioned later, is that it's brought in too late because there's a natural reluctance to accept the fact that you do need to go into hospice. But on now the glass half empty side, we still use a lot of technology toward the end of life. This happened to my neighbor who was dying of prostate cancer. He got sick, so they put him in the intensive care unit. They got him kind of squared away, but he was still in terrible shape when I visited him in his home. And so kind of why in the world did all that happen? But there's a technologic driver. You know, I always say, if you go into a barber shop, you're very likely to get a haircut. If you're transported by Medic One to a high quality emergency room and you're sick, the reflex is to save your life, to do whatever. You know, we're all signed up for CPR, we're all signed up for ventilators, unless we say otherwise. And he hadn't said otherwise yet. So he was in that third that received the ICU care in the last 30 days. And you know, some of that is okay, but we still are leading the rest of the world in the use of technology in that situation. So somebody asked a philosopher how he would like to die, and he said, well, gee, you know, when I least expect it. And most of us will not die that way. It won't be just a massive heart attack and lights out. It's much more likely that we'll develop a chronic illness, a cancer, heart disease, and then we'll get periodic flare-ups and our health will decline. And then we'll get to a point at the end where we have to, this is the difficult situation. And Atul Gawande in his book, Being Mortal, writes about that. And he had an article in the New Yorker called Letting Go. How do we let go? And it's hard for patients and families to let go. It's hard for doctors to let go. At some point, there's something that's going to take us at the end. So there's really three pathways we need to think about as we approach the end of life. Do we want life prolonging care? Do we want CPR? Most people, when we get frail and get up in our 80s, would say, you know, I might want everything else, but I don't think I want CPR. If my heart stops, that's not a bad way to go. Kind of depends on you, and I'll get into the survival statistics there. Choosing a ventilator is a little bit different. Let's say you get a pneumonia and you're very sick. Would you be willing to go on a ventilator for a few weeks? You need to set some limits or values on these things as you make these choices. Then we get into selective medical care. Would we want an IV? Would we want a feeding tube? Would we want antibiotics? And then ultimately, when we really get into those last 6 months of life, a lot of us would choose comfort care. This is when we say we really want our care just focused on comfort. We're not going to want the chemotherapy. We're not going to want the intensive care unit. We're only going to want hospitalization if it's really necessary to control our symptoms. Otherwise, please keep us in a home-like environment. So those are the kinds of things to think about. Now, television, CPR, 66% survive and walk out of the hospital. That's not the case, unfortunately. overall population, if you look at it, it's about 15% survive CPR. Now, if you're 50 years old and you're in Western Washington and you've got a good Medic 1 unit and you've got a shock of rhythm, it's going to be higher than that. But that's not pertinent to our population. As we become frail and elderly, maybe a 5% survival CPR, but you can end up with broken ribs and wind up in skilled nursing and then wind up in chronic nursing care. So it's really something that you really need to think about in terms of the risk of undergoing CPR. If you have very advanced disease, advanced cancer, less than 1 in 100 will survive, and there your survival and quality of life is very poor. The ventilator, of course, if you say, I want CPR, it means you're going to get a ventilator because that's part of CPR. But let's say you don't want CPR, you can want to be do not attempt resuscitation on your post form, but you can still choose full treatment, which may include a ventilator. And we know a lot about ventilators. They're just a breathing machine, basically, with its pros and cons. But it's a very common way to support you when you're critically ill and can't breathe on your own. I'm kind of running a little bit long, so I'm going to kind of just quickly go through some of these things with artificial nutrition. It can be withheld if that's your wish. It's not a good idea at all in dementia to use artificial nutrition. I do have a story in my book about a woman who was getting blood transfusions with advanced dementia and the dilemma that raised for the family. Antibiotics, Ezekiel Emanuel said, I'd never want an antibiotic. But on the other hand, I think most of us would take an antibiotic to get through a period of whatever. Feeding tube is something else, whether we would want that or not. If you had a severe stroke and were semi-paralyzed and were not recognizing your family anymore, would you want that feeding tube to keep you alive? Those are the things you can't necessarily spell out, but you can tell your family or your loved ones, these are things that are really important to me. I need to be able to recognize you. I need to be able to interact with you. I need to be able to have clear thinking. Whatever is important, then let people know. Comfort care, that's where you get palliative care and hospice involved. What I really hate to see physicians say is there's nothing more we can do for you, because in medicine and nursing, there's always something more we can do, particularly with palliative care. We need to keep a connection. We need to provide support. And there's a book now about compassion written by 2 doctors. It's called Compassionomics. And it's an interesting book saying, if we can learn to show compassion, it's good for the giver, it's good for the receiver, and it's actually good for medicine. So something that we're trying to get out, because quite honestly, a lot of medical encounters don't have near the level of compassion that they should. So I won't really go into hospice. I'm sure you've had experience with hospice. It's Medicare benefit. And the question there is, when should I go into hospice? And what I encourage people to do is at least have a conversation, see what hospice can offer, and get on their radar screen and say, okay, this is what we offer. Let us know when you're ready, so that there's not this last minute within 24 hours you're going to die, I want hospice. And a lot of people don't get into hospice until their last 3 days. And that's always a mistake, unfortunately. Palliative care is a separate specialty in medicine now. There's not enough of them, but if you're in the hospital and things aren't going well, you're confused on your treatment plan, you're suffering, you really can ask for a palliative care consultation. They try to give you the guidance and focus on your symptoms, try to arrange emotional support, coordinate your healthcare teams, that kind of thing. Again, hospice is delayed in about half patients. So who's going to speak for you? I have a video I could show here, but I think I'm going to skip that just so we can take more questions and talk a little bit about the durable power of attorney for healthcare. This is called your surrogate or your advocate. Who's the best person for the job? I think it's somebody that knows your heart, that is able to stand up, sometimes against other family members, sometimes against your healthcare team, to truly advocate for you. In Washington State, if you don't have a durable power of attorney, it would go to your spouse or domestic partner. But if you don't have a spouse, it would go to your adult children. This is if you don't have a durable power of attorney. And this is the problem I would run into in the intensive care unit. The adult children would all have to be in agreement under Washington state law. And as you know, your adult children don't always agree with each other. So maybe I can go into death with dignity in the question and answer portion. The one thing I can just say about it, currently about 0.3%, about 1 in 300 deaths in Washington state are related to implementation of death with dignity. About 280 or so people a year end their lives that way, and about 168 physicians wrote the prescription. But End of Life Washington, formerly Compassionate Choices, has all the information that you can need on this. Voluntary stopping eating and drinking is another option, and that's exactly what it says. You get to a point in your life, maybe you don't qualify for death with dignity. Diane Rim wrote a book called My Way about her husband's choice to do this. Phyllis Schachter up in Bellingham wrote a book about her husband's choice to voluntarily stop eating and drinking as a way of ending his life, as they were both descending into dementia. And there was an international conference at Seattle University School of Law a few years ago. It is legal. It's not against Catholic doctrine. We all have a right to eat or drink, or not to eat or drink, but it is a difficult mode of choice because of thirst and the time it takes, but it is a viable option. So I think you know about all the forms you need to fill out, and you certainly all know about the post form. It is going to get a little bit more politically correct. In the new version, it's going to be called the portable orders for life-sustaining treatment, because it can be ordered by physician assistant or nurse practitioner these days. So it's not strictly physician orders, but there'll be some other improvements in the post and also in the advanced directives. So I mentioned the dementia directive and the issues with directives. There could be problems in finding them, as I mentioned. They should be updated with a change in health, for sure. And it can't cover all situations, but you can try, particularly with an essay about what is really important to you, what matters the most to you. So there are 10 top books about this on the conversationproject.org. My book obviously is not in the top 10, but there are really a number of good books. Being Mortal is my favorite. Katie Butler has one on dying, I think it's called Dying Well. And I do have this blog, End of Life blog. So there are all other resources for you. And that's the book, and I hope you get a chance to read it. If you do read it, and you can comment on the Amazon site, my publisher likes that. So anyway, I'll stop sharing here. I did run over, sorry about that, Lee. and may have tried to cover too much ground too quickly, but love to take some questions.
We're ready for questions. You can either put them in chat or I hope electronically raise your hand, but I'll do my best looking at the holiday squares. Barbara Lee, please.
Unmute myself. This was a wonderful presentation. Thank you, Dr. Demain. And I just finished Being Mortal by Dr. Gwande.
Oh, good.
I am hoping that at Heron's Key, we can put our pulse forms on the door under our sink, like they do at Skyline and another retirement home where we live, because my husband asked where our pulse forms were the other day, and I said, well, they're supposed to be in the freezer. Well, they had fallen down below the 2 trays. I know this is more of a comment for Heron's Key and not for you, but wonderful presentation. Thank you very much.
I'm glad you're trying to standardize. You know, when I was thinking about this, it took us about a year to implement this, by the way. I called the leading lawyer at Leading Age in Washington, D.C. and said, you know, what are your best practices? What are your recommendations about storage of pulse forms? What are your recommendations about defibrillators and stop the bleed and things like that? And he said, well, you know, if you've seen one CCRC, you've seen one CCRC. He said, everybody has different practices, state laws are different, and we don't really have best practice guidelines. And I thought, well, okay, but maybe we can do something in the state of Washington, among the CCRCs anyway. So I'm hoping that we can have the energy to standardize things that, you know, it'll be a little different for each unit, but at least we'll have an argument within our own institution if all the others are doing it and we're not, you know, that kind of thing.
Jim, while you were talking about statistics on where people die, Jerry Walton asked in chat, how many die in adult family homes where care is provided?
You know, I don't know that. That's a really good question. In King County alone, there's 1,300 adult family homes. You know, they can have up to 6 people. And I actually trained as an ombudsman at one point, and I visited some adult family homes. And I can find that out, but I don't know. You know, I remember way back when some of these institutions, not just adult family homes, did not want to have people die in their institution. And so if they become very ill, they would call 911 and ship them off to the hospital. But I don't know if that happens in adult family homes or not.
Pam or Clark Rowland, please. Can you guys unmute yourselves?
Sorry, I was talking to myself. Dr. Demain, thank you. It's been a wonderful program, and I hope you'll come back again. But
I'd love to come down there live because it's so much more meaningful to do it that way.
Yes. Are you familiar with the 5 wishes
Yes.
form? Can you speak to that, either pro or con, or would you prefer not to?
No, I think it's fine. There's a gal in Seattle, her name is Trudy James. She's a retired chaplain, and she did a film called Speaking of Dying, and she runs groups like of 5, 6, 7 people working on their advanced directives, and she does a wonderful job, and she uses 5 wishes. I know I've heard some comments from people at End of Life Washington who feel that it's not pro death with dignity enough. I don't know exactly what the objection is, but I think it's a good standard form, and it does have values built into it, which I think is really useful. I look forward to the Honoring Choices offering as well. It's going to be a little confusing because we're going to have so many variations of the form out there. But, you know, honestly, at the bedside, I would say, yeah, they've got their advanced directives, but then you end up talking with their loved ones, their advocates, because, you know, I had one lady, and it's a story in the book about a lady that ruptured her abdominal aortic aneurysm. The big artery in the belly was rupturing, and she was so ill for weeks and weeks and weeks, and we thought she wasn't going to make it. And so we kept discussing it with her son, who was a firefighter in Bellevue, and he was such a cheerleader, and he was so positive. And you know, we were wearing out, and the nurses were wondering if we were just prolonging dying. But having that advocate there was so helpful to all of us. So we tend to do a lot of the fine tuning and negotiating and the nuances by discussing with your loved ones, because you can't put everything down on paper.
Right. Thank you.
Yeah, thanks. Good question.
Jim, you mentioned in the book that Washington State passed the Death with Dignity law in 2009. Do you see a movement to make it less restrictive in terms of the individual having to be physically able to administer the sodium pentothal or whatever it is? That is, that you also mentioned that the Canadian system is a little bit different. Is there any movement towards changing the guidelines in Washington State?
Yeah, there's a bill in the legislature now, not to quite do that. You know, the bill is to allow nurse practitioners or physician assistants to be prescribers, which would certainly expand the list of providers, and to shorten the 2-week waiting period, because sometimes you have somebody that's actively dying, and making them wait 2 weeks just doesn't work. In terms of allowing somebody else to administer, that we still haven't crossed that line. I think that protection is still there. Whereas in Canada, it's allowable for the physician to directly administer either orally or intravenously the medication. So they've kind of gone the way that some like Belgium or Holland has, in terms of much more active medical assistance in dying. Whereas, you know, you mentioned the drug. We used to use secobarbital, but the drug companies did not want to be associated with that, and they basically pulled the best drug off the market. And so now they have to use a cocktail of about 4 drugs, and they do work. It's digitalis and amitriptyline and phenobarbital and a couple of others that will basically stop the heart. But it's difficult to train people. The state that's probably doing the best job is California. They just passed their law 2016, and they actually have a list of about 400 people that they're communicating with, and they formed an Academy of American Clinicians for Medical Aid in Dying. And they are trying to standardize procedures and to train people, because we don't really have any good way of training people enough, as much as we should. Although the organization End of Life Washington is well run, and they're staying within their guidelines. But there still is some under the radar things going on in the state of Washington. I was down in California at a bridge tournament, and a lady said, "Oh yeah, I'm going up to Washington and I'm going to be a death navigator." And I said, "What in the world is that?" She said, "Well, I'm going out into a rural community where this woman doesn't qualify for death with dignity, but we're going to use a thing over her head, kind of a helmet with a tank of helium, and that just deprives her of oxygen, and she goes to sleep and dies rather quickly. And then we get rid of the equipment, and nobody knows. And they kind of come out of the Hemlock Society down in, I don't know, any of you read Final Exit? It's a very creepy book by Derek Humphrey, who's still alive, I believe. There's even a chapter in there called Going Together, where you and your wife can, or you and your husband can go together. But it's kind of a how-to book in terms of that. And in an odd way, he was a pioneer. But I think the states are still being very careful and not stepping over the line. It'll get difficult. At some point, likely it will, continue to allow medical provider to administer. But as far as I'm aware, it's not. Most of the states have patterned their rules after Oregon. Oregon was the first one. You're muted, Lee.
Sorry, Jerry Walton has a question. Jerry?
Yeah. Yes, I was just wanting to ask a question, but first related an experience. I recently, about a year and a half ago, went through this with my sister, Molly. And what happened is that I had to take care of her finances for about 5 years. And then the last 2 years, I didn't realize it at the time, but she was in the process of dying. She had cancer, and it was slowly taking her away. And the best way to learn about how to handle a situation is to go through an experience. And so when it's all over, you look back and said, oh, I wish I could have done this and wished I could have done that. Wish, the woulda, coulda comes up. And I think my main question would be, how could we have talked more about how hospice would have entered in at the end? Because what was unfortunate, my sister never really got a chance to be with her loved ones in the final week. She was trying to be a survivor of cancer and fighting it and not really letting go. And I just wondered, how could that have been different? What would I have done differently to get that started in the process of dying?
Well, yeah, it's a very, very tough question. And I have a story in my book about a fellow that I had actually called up, and even though he was a friend of somebody that I wasn't treating, trying to suggest, why don't you at least have a conversation with hospice? And it's kind of an existential shift, you say, okay, maybe I'm dying, but sometimes the doctor hasn't brought it up. And, that's very powerful if the doctor is willing to say, your time on this earth may be short. Why don't we at least have a conversation or get the conversation started? And Ellen Goodman and the Conversation Project has a lot of little tricks to starting the conversation. Yeah, remember Mr. So-and-so down the street when he had this or that, you kind of depersonalize it. My neighbor whose husband had come back so sick with the prostate cancer, I said, well, what are you going to do if this heart stops beating? She said, well, I won't call 911. I said, well, why not? She said, well, I don't want him, he doesn't want to be resuscitated. And I said, well, if you talk to hospice? And she said, nobody's mentioned hospice. So it's kind of the elephant in the room, how do you get around that? I don't have an easy answer for you, but it's hard for doctors to tell somebody they're dying. Particularly some oncologists, because they'll say, oh, we've got a new drug, or there's something in the pipeline here. It might give you another month or two.
Yeah, that happened. So yes,
Yeah,
that's familiar.
it does too much.
Okay, well, thank you.
Sure. Thanks for the question.
Diane Olson, please.
Yes,
Diane?
I can relate to that experience. It was 3 months before my husband passed away. He had been ill for many years. And at the 3-month point, I called hospice to make an appointment for them to come over. And my intention was to introduce ourselves. So when the time came that we needed hospice, they would, we'd have a connection already. Well, the head of hospice came out and talking to us, and my husband was bedridden by this time. And she said, well, we can bring a hospital bed in tonight. We can start you with the visits. And I thought, wait a minute, we're not there yet. Well, I guess we were, because it was 3 months later when he passed on.
Mm.
So,
Did you eventually use the hospice?
oh, yes, we started that night.
Oh, you did? Okay.
Yeah. Yes. And
No,
so
it can feel terribly abrupt, when that, it just suddenly happens.
oh, it was. I did not expect that at all.
Yeah, I'm sorry for that.
Thank you, and enjoyed your presentation very much. And the first couple of points you made, I will make an appointment with my attorney for a codicil.
Okay, great.
Thank you.
Yeah, sure.
Camerellen, please.
Is there a protocol? Is a advocate not able to mention hospice to the doctor, or is that something that kind of is hopefully just evolving?
That's a good question. No, your advocate can advocate for just about anything, because you've given them the right to speak for you when you're unable to speak for yourself. So you're no longer competent for making those decisions. That means your advocate can do all your healthcare related decisions for you, to speak for you. Your financial advocate is something different, but
Right.
certainly, yes, they can say, doctor, he did not want to go to the intensive care unit. That happened to one of my patients who did not want to go to the ICU and be put on a ventilator. He had terrible emphysema. And I was out of town, and my colleague kept saying, we can get you through this. We can put you on a ventilator, and it's not so bad. And the wife, who was the advocate, basically had to throw my colleague out of the room.
Oh,
You have to be pretty strong and
Oncologists. too.
understand those wishes.
thank you.
Are there other questions? If not, if you all would like to turn on your videos and your audio and say thank you to Jim for a really thought-provoking presentation.
Great to see all the faces.
Thank you.
Thank you.
Thank you.
Thank you very much.
I admire this group for coming out en masse. Thank you so much.
Thank you, Dr. Jim.
Yes, thank you.
I don't know where I'm at.
There you are. Thank you so much.
Okay, yeah. Lee, thank you.
You're very welcome.
Yeah. Thank you. This is great.
Okay, take care. I'll go ahead and sign off.
You too.
You
Okay.
too.
Okay, bye-bye.
Goodbye, all.